So we are very excited to have Mark Sendak as our next speaker. He's the Population Health and Data Science Lead at Duke Institute for Health Innovation. He has led his team to integrate over a dozen different data-driven technologies into clinical operations. He really is a world leader in this domain. He has also co-inventor of a software to scale machine learning applications. Some of the examples of the tools that they have developed and infrastructure they have developed includes Duke's Health Accountable Care Organization and COVID Pandemic Response Network and Hospital Network. With that, I would invite you, Mark, to go ahead. There you are. Please share your slides, and we're very excited to have you.
Thank you for having me. This is a community that I've seen grow over the years and really excited to be here today. So I'm going to start a timer to keep myself moving. And hands down, my talk is going to build off of a lot of the earlier content. So excited to be here. I'm going to talk a little bit about our team. I'm going to talk about principles and practices that enable us to effectively integrate our ML AI solutions into workflows. And then I'm going to call out a few potential opportunities to partner. I'm really excited about the size of the audience here. I'm impressed. Y'all did a great job. So my team is the Duke Institute for Health Innovation. Our mission is to catalyze innovations at Duke. I will note that we are not explicitly or implicitly an AI or machine learning group. It's just we started in 2013 and this has become a core capability. And our approach is really grounded in human-centered design. We work with end users for every project and we iterate with end users on our solution design and development. We have two different mechanisms to source problems that we work on. The right-hand side is more of a commercialization, IP generation, and investment opportunity for inventors at Duke. The left-hand side is where most of the projects that I'm going to talk about sit that are more related to workflow integrations within our delivery system. And this is a top-down, bottom-up approach. I'm going to dig into this a little bit more because I know this came up in prior talks. Identifying the problem and bringing stakeholders around is actually maybe the most important practice to be able to set up a project for workflow integration. So a few things that kind of guide us. We really aim to push the boundaries of what Duke is able to do. We try to allow Duke to have updated representations of health status on as many patients as possible. And the other thing that's really important is we don't see ourselves as the innovators. So even though I work for an innovation team, we are trying to empower our frontline workers and develop tools and services so that it's more self-service innovation and really trying to scale the way that clinicians feel empowered to be part of healthcare transformation. We work across the disease spectrum, across care delivery spectrum, and are agnostic. And every year it kind of varies, which keeps the job fun. So principles and practices. We've been iterating on this for a few years now. I am going to focus for the next about 10 minutes on the practices that are most important to workflow integration. And I will say that Vikas talked a lot about this earlier in this session, but it does start with building to show value. Integrating anything into healthcare operations does have costs associated, and you need to have that alignment up front. So I'm going to start with how to ensure that you're working on the right problem. So one thing for us is when you're doing something new, we need to be looking ahead of the organization. So I often use the analogy of train tracks. And I view our team, our mission is to be laying train tracks for the heavy, slow-moving vehicle that is healthcare. So we need to be looking ahead. What is the direction we need to be going in? And then obviously we help the train start riding on the tracks, but then we need to actually get off the train and then think about what are the next tracks to lay. So to be always looking at the new frontier of where to be creating opportunities for care delivery. The other thing is we really focus on the conversion of ideas into products and solutions. And we have a strong belief that the best solutions are going to come from our frontline staff. And we try to convert that into AI ML products, as well as all sorts of other types of products and services. And I will say it's really important, actually, in our experience, to not be focused purely on AI or ML, because a big part of our job is to actually minimize the engineering effort that needs to go into building solutions. Most problems are not solved by AI or ML. And the last piece is to focus on adjacent and transformational opportunities. I will say that if you're doing core optimization, it can be tough to really make the business case for AI or machine learning. Whereas trying to justify the cost of a high cost technology, you need to be targeting kind of opportunities that your existing core capabilities are limited in being able to tackle. So next is, how do you align the different stakeholders to set up a project for integration? So I talked a little bit about our request for application process. Here I'm going to map out some of those details. So in our experience, we've been doing this now for about 8 years. Yeah, 8 years. I've been with the team 7 years. So it's crazy how long it's been now. But it really is a top-down, bottom-up approach. So the way that this process starts is every year, my team director, Suresh Balu, he meets with the C-suite, the chancellor, hospital presidents, department chairs, and agrees on 4 to 5 strategic priorities for the organization. Those are typically broad statements. It can be patient safety, novel patient engagement mechanisms. It could be hospital-acquired infections, provider resilience, burnout. So these are broad statements. We put out the RFA, and that gets publicized through clinical and operational leaders, and we solicit proposals from frontline staff. We typically get 50 to 70 proposals a year, which I would say maybe a third every year are related to AI or machine learning. I need to build a model to solve X problem. The next step is problem selection. So we send out every written proposal to clinical and operational leaders for written reviews, and then the top 20 projects go to the C-suite for oral presentations. And I would say it also, having it structured in this way, we as the innovation team are aligned with the innovators. We're not the gatekeepers of resources, but we actually help coach the teams for their 5-minute pitches to the C-suite. When senior leadership decides on the projects, we then go back to working directly with frontline staff to define the problem, interview, observe stakeholders, design, develop solutions. And then when it's time to actually make that conversion from a pilot to full-scale deployment operationalization, we continue to engage C-suite at midpoint and year end. That way we can ensure that resources are allocated so it's not just integrated in one small setting, but continues to kind of scale across the organization. And we really do view it as our job as well to be continuing to align and communicate across these different stakeholder groups. One of the other things that's key in this process is identifying which leaders you need to be engaging and which managers you need to be engaging. And I will say, as someone who did not do an MBA, went to medical school and then went to policy school thinking policy was going to solve problems, I didn't even know what the difference between management and leadership was. But a lot of new workflow, new process requires vision. It requires very strong communication abilities, being able to align people, inspire people to do things differently. And oftentimes it's a distinct group from folks who are able in position to put all of that into practice. So next is starting with building minimal viable solutions. And I will say that this came up in the earlier session with the keynote. We really don't uncouple the components of our products. We build solutions. Sometimes an AI model is a part of that. Sometimes it's not. Sometimes notifications are a part of it. Sometimes we have to address other workflow barriers. We have to create new scheduling systems. We have to create new clinic availability to be able to put something into practice. So the other thing too is as soon as you start identifying that you're able to create value, continue to iterate and don't let the perfect be the enemy of the good. And we're very strong kind of participants in lean startup methodology. This is just an example. The first version of our Sepsis Watch system was built on a PDF. And this was built by a medical student who, without writing a line of code, just kept iterating on mock-ups of what the screens should look like. And ultimately that was coded up into the enterprise software that we continue to use to this day that's been live for 3 years. So another big part of workflow integration is these transdisciplinary partnerships. So here's a quote from a few years ago. This was the first piece I ever read by Ziad Obermeyer, who today is famous in this field. But it really talks about how often clinicians are not engaged in the development of these types of solutions, and really questioning how much of an impact will we see if clinicians continue to not be engaged. So we really do try to bring these different groups together. Most publications still don't have this type of interdisciplinary team. And what we found too is that these types of expertise are siloed across the organization. So over the years, we've had to develop workforce training programs that bring these groups together. So we have clinical training programs that we run. We have training programs. I know that I saw Joe Futoma was on here earlier. I don't know if he's still here, but we've worked a lot with PhD students, undergraduate students, and even faculty, and get them involved in working elbow to elbow with data science, machine learning experts. The next piece is you actually have to staff these projects. And so it's not, these can't be entirely academic projects to do workflow integration. You need full-time staff who understand how to develop solutions, project management, change management. A lot of these are terms that I had no idea what they even meant when I was going through medical school, but really recruiting and retaining talent that can bridge across these different domains. And then the last kind of core practice is you have to be willing to restructure workflows to allow integration. So here's just one example. This is a chronic kidney disease algorithm. We ran this within an accountable care organization, identified hundreds of patients who had impending kind of disease deterioration, and we had to develop an entirely new workflow to bring a group of people together to review high-risk patients and then make care recommendations. Similarly, for our Sepsis Watch algorithm, we had to develop an entirely new workflow, entirely new types of roles. And this is one of my favorite quotes from one of our qualitative studies. We literally are changing the way that people practice. And so one of my favorite images about how rigid healthcare organizations can be. So Kevin Shulman, he was one of my first academic mentors. He's out at Stanford now, and he often includes this picture in his presentations along with kind of a tongue-in-cheek comment. So what other industry has their org chart in bronze from 100 years ago? So this picture is in the entrance of our clinics, where these were the first department chairs when Duke Health was established 100 years ago. And I will tell you that the org chart today looks very similar. So we do have to question, how do we really adopt technology and integrate technology into our workflows effectively if we're not willing to restructure? So on the right-hand side, this is just a few examples of how we've literally had to restructure the organization. And I also thought one of the best examples of this was New York City during COVID actually moved entire public health functions out of departments and into other parts of the city to be able to execute more effectively. So we have some examples from COVID that I'm not going to get too far into because I want to make sure we have time for the Q&A. So quick review of the best practices and philosophies. I do want to call out a few partnership opportunities. We always are looking for external validation sites. I think integrating these into workflows in one site is always meaningful, but then the question is, well, how will this work in other environments? How generalizable is this system? One of the other things too, especially with workflow integration, is the value of social science collaborators. So I think quantitative data can be really good at looking at effect sizes and estimating kind of performance, but it doesn't tell you why or how something works. And I think we clearly have seen in recent years the social implications of technology. So some of our most valuable partnerships have been with social scientists. And we have an amazing partnership with Kate Kellogg at MIT right now that's looking across all of our projects and what are the best practices for workflow integration, and excited to share updates about that in the coming months. And one other just opportunity with some folks who are on this call right now, we're actually putting together a call for submissions. It's going to be launching next month to have health systems submit manuscripts about often behind the scenes work about what it really takes to integrate these types of solutions into healthcare. So thank you. And if you're interested in the work that we're doing, come join us. We are growing. So thank you, everybody.